My name is Tzvika Greenbaum. I'm a physiotherapist. My area of expertise is the cervical spine and the masticatory system. This is actually my favorite region of the body, and I'm going to speak about this favorite region of the body throughout this lecture. So, hi everyone in Belgium. Let's start our lecture. So, first of all, I will share with you my screen, and we are going to speak today about temporomandibular disorders and the cervical spine. I will introduce a little bit more about myself to those of you who don't know me before. There's the left side, you can see my academic background. In the middle, you can see the medical center that I work for. And on the right, you can see my teaching background. So starting from first degree in Haifa University, bachelor 2004, then heading to the University of South Australia for a master in muscular, skeletal and sports physio, and then continuing to the PhD that I've just submitted almost a year ago. Now it's under final referees, international referees decision. Actually, the decision has been made, but formally I'm still not a doctor, still not a PhD, so I'm still a candidate today in this lecture. I work in Herzliya Medical Center, which is still working during the Corona times. So I still see patients, the brave patients that are still daring to come to see physiotherapists. I still have an opportunity to treat them. And I teach in the academic field in Ben Gurion University. I teach undergraduates for the orthopedic musculoskeletal assessment and rehabilitation course. I teach dry needling for the Science Academy for the last 5 years, and I teach the cervical craniomandibular therapeutics as the main lecture. This is basically my business. It consists of 3 courses. One is the lower neck, 2 days. The other is the upper neck, 2 days course, and the last one is the temporomandibular disorders course. And my most special combination that I really like is combining the upper neck and the masticatory system, and that was actually my PhD topic, and I'm going to speak about it today. I teach in different countries, all over Europe, where hopefully I'm really hoping to return and teach my courses overseas. I teach in Belgium a lot, in Greece, in the Netherlands, also, of course, in Israel, in Slovakia, Hungary, Cyprus, Hong Kong, Switzerland, and some other countries. So the TMD, temporomandibular disorders, and the upper neck are really in high demand courses, also in Belgium. So really happy that it's becoming an interesting topic for physios. So I will start my lecture with this small question. Do you guys know what is the most common chronic and disabling musculoskeletal disorder? Okay, what is the most common chronic and disabling musculoskeletal disorder? And the answer is that temporomandibular disorder is only second to the chronic low back pain in the prevalence of musculoskeletal disorders. We are talking about 5 to 12% of the general population coping with either persistent or recurrent temporomandibular disorder. So I think sometimes when we see patients in clinic, we are not sure where are they, these TMD patients, and they are out there, but they are not getting to physiotherapy enough probably. And I hope that they will start to come more and more. If we are ready to treat them, then we are inviting them to come and to get the treatment. That's my point of view. So we'll start our lecture about the background for temporomandibular disorders and orofacial pain, and then we will concentrate more about the connection between the upper neck and the temporomandibular disorders, and there I will present you findings from my PhD that was all about this topic. So starting from the background of orofacial pain and TMDs, let's define first orofacial pain. So it's a very wide entity that includes TMD and some other possible medical disorders. So orofacial pain is wider than temporomandibular disorders. But what are the differential diagnoses for orofacial pain? We can see primary headaches as a very common differential diagnosis, head tumors, ears, nose, and throat issues, dental issues, and chronic pain syndromes like fibromyalgia. So just remember that orofacial pain is wider, and under that umbrella, you can find temporomandibular disorder, which can be defined as a collective term embracing several clinical problems that involve the masticatory muscles, the TMJ, and associated structures, or both. That's the definition for temporomandibular disorders. So the epidemiology of temporomandibular disorders is very wide. You can see that almost 75% of the population has some signs of TMD, clicks, deviation, pain during palpation. But luckily, only 1/3 of the population complain about symptoms of TMD during lifetime. 15% of them develop chronic pain condition. And we can see that we have more female than male. So the ratio is really high, 3:1 to 7:1. And mainly females during the fertility age. Remember, that's what you will see if you treat TMD patients, temporomandibular disorder patients. In the general population, we can see, generally we're in TMD, not only the general population, but in TMD, we're talking about 3 main disorders, 3 groups of disorder under the TMD. We have the disc-related TMD, the pain-related TMD, and the degenerative joint disease type of TMD. But in the general population, you can see that the disc-related TMD is the most common one, followed by the pain-related TMD. But inside the TMD population, you can see majority of pain-related TMD, followed by the disc disorder. If I could ask you now, what is the reason? I hope that you would answer that's because pain brings patients to clinic. That's why we see more pain-related TMD in clinic. But remember that we have 3 types of temporomandibular disorders. One is discogenic, clicks, etc. The other one is a pain disorder. And the last one is a degenerative joint disease, which is mainly osteoarthritis. The etiology of TMD is, I really like this model, simple model. If you want to cook a TMD to prepare a temporomandibular disorder, then normal function luckily is not enough. But if you add to that iatrogenic events or parafunctions, these are functions that we do with our masticatory system that we don't have to do, like cutting the nails, like bruxism, like chewing gums, these kind of things. And if we add some emotional stress, and if we add some protracted pain from the cervical spine mainly, that's even not enough to develop chronic temporomandibular disorder, but we also need to have some predisposition, genetical predisposition to that. So if you look at this model, and you want to prevent patients from becoming chronic TMD or orofacial pain patients, then the concentration will not be on normal function, will not be on the genetics, but it will be on parafunctions, emotional stress, and protected pain. Iatrogenic events usually have already happened, so we cannot influence it so much. So main focus of us as therapists would be reducing parafunctions, reducing emotional stress, and reducing protected pain, treating the neck, in other words. You can also see that temporomandibular disorder patients are very likely to have some other comorbidities. So here you can see the prevalence of the comorbidity in the overall population versus in the white one, and in the black you can see the prevalence of this comorbidity in the temporomandibular disorder population. You can see so many disorders that are comorbid together with temporomandibular disorder. So you can actually say that TMD patients are more complicated patients than healthy controls. That's something to remember when you see a TMD patient, a chronic TMD patient. Just bear in mind that it's very likely to have some other medical conditions. Most of them are related to the autonomic nervous system. So it's a sensitivity of the autonomic nervous system that brings many other disorders. That temporomandibular disorder is only one of them. That's the paradigm that we work with, and that's the paradigm that we understand today. Now, as physios, I suggest here a model, a clinical model, that we can classify our patients and manage them accordingly. So if you have a headache or orofacial pain patient, which is quite the same thing, first of all, you consider the social component of this patient. So what are the levels of anxiety? What are the levels of depression of this patient that suffer from headache and orofacial pain? Secondly, we can actually classify these patients into four main groups. One is the musculoskeletal condition. All right, these are patients in green that we can manage very successfully. The second group is a non-musculoskeletal condition with a musculoskeletal component. For example, if you have a sinusitis type of patient, but also he develops some tightness in the masticatory muscles that is secondary to the sinusitis. This is a non-musculoskeletal patient with a musculoskeletal component. Could be also a chronic migraine patient that develops some trigger points on his masticatory or her masticatory system, or in her or his neck region. All right, and then we have the third group, which is a non-musculoskeletal type of patient without musculoskeletal component. For example, the same migraine patient that has no musculoskeletal impairments. So these patients, of course, we have nothing to do with them as physios, apart from diagnosing them and referring them maybe to other health practitioner. And of course, we have the red flags patients that we need to screen and return to the medical professions, to the doctors. So if you classify or categorize your patient, if he has a musculoskeletal condition, it could be only two main conditions. One is the temporomandibular disorder, which is a musculoskeletal condition, and the second one is the cervicogenic headache. These group of patients are very likely to respond to our treatment. That's why it's very important to categorize them. In the yellow, you can see the non-musculoskeletal condition with musculoskeletal component. Then our question is whether we have a cervical spine involvement or a masticatory system involvement. Then if we have such an involvement, then we can do something about it. We can still treat these yellow patients and green patients. We can treat these patients, but the other orange and red patients we cannot treat. So it's very important to classify and categorize our patients. That's the model that I suggest also in my courses. So after we have a general model of categorizing our patient, and we know a little bit in this lecture about temporomandibular disorder, then we can head to the jaw-neck connection, which is the lecture today is mainly about it. So what do we know and what don't we know about this connection? And the lecture you see now is the background lecture for my thesis, for my PhD. And inside this lecture, I have added some answers that my PhD supplied. So I will actually add the findings from my PhD to the things that we know, and also more importantly to the things that we don't know, to the gaps that we have in the literature in that regard. So that's the PhD, that's the title of the PhD, which I presented in the World Conference of Physiotherapy. And you can see the title, Characterization of Upper Cervical Spine Performance and Pain Parameters and the Prevalence Incidence of Cervicogenic Headache patients in patients with temporomandibular disorder. So two main questions. First of all, what is the performance and pain parameters of patients with temporomandibular disorders? All right. And the second one is, what is the prevalence and incidence of cervicogenic headache in these patient groups? So, of course, what you can see here is the poster, which is quite complicated for this lecture, but it's just for the title that you will be able to watch right now. So the first thing that my research group was, as you can see, categorized into 4 groups. We had a pain-related TMD group, remember, before in the background. We have pain-related TMD group, we have the intra-articular TMD. We did not have the degenerative joint patients because they are older and they cannot play as a benchmark for the other groups, but we did have a mixed group of pain-related and intra-articular TMD patients. And of course, we had also healthy controls. So 37 pain-related, 17 intra-articular, 20 mixed TMD, and 42 healthy controls, sum up with 116 patients. You can see that in age and gender, the majority in age, they were quite similar. They were very much between the ages of 20 to 40, the vast majority. And you can see that the majority of patients were females, same like the epidemiology that I presented before of TMD population. So first of all, returning to what we know and what we don't know about the involvement of neck in temporomandibular disorders, we can see that if you ask clinicians, dentists and physios about the connection between the two regions, they will tell you for sure, the physio will tell you, my neck disorder patient do tend to suffer from a pain in his masticatory system, and the dentist will tell you definitely my my bruxist patient or my pain-related TMD patient tend to complain also about his neck. But that's not enough for us for science, yeah? Functionally, we start from several connections between the neck and the jaw. The first one is a functional connection. If all of you right now will open your mouth wide, most of you probably will extend their upper neck. So you can see a direct connection, a very simple connection between the head on neck and the jaw on the cranium. If we want to open the mouth wide, then moving the head up will help us. And you can see that the cranium is connected to the atlas and the mandible is connected to the cranium. So biomechanically, for sure, we have a connection, but that's not the big issue because that's quite clear for all of us. We also see that patients with TMD tends to complain more about their neck if you let them feel the neck disability index. And actually, we did it also in the PhD project, and you can see here that the average of healthy controls in the neck disability index score that runs all the way up to 60 was quite moderate. You can see that the average of our TMD patients was higher. So significantly, they were different. The TMD patients and the healthy controls, that's quite it's approving actually what other studies showed before. So these are things that we know about the connection, but the PhD made some strengthening of these findings. Another connection between the two regions, or maybe the most supported connection between the two regions, is the pain connection. Because you can see that a noxious stimuli that comes from the upper neck blends with noxious stimuli that comes from the trigeminal system, and that's what we call convergence of these two regions. So if you have a noxious stimuli for, let's say, facet joint of C2-3, you're very likely to experience pain in your trigeminal distributed region. And the same thing if you have some noxious stimuli from your masseter, for example, on the right, you're very likely to have also some sensation of pain in your upper neck because of this convergence of the neuroanatomical structure of the trigeminal cervical nucleus. So we have a same nucleus in the brainstem that receives input from the upper neck and from the trigeminal system, and that's the mechanism for referred pain from the neck to the face and face to the neck. That's quite strongly evidently supported. And that's the explained mechanism for cervicogenic headache as well. You can see in our study that, remember, we had the intra-articular group, which is not mainly a pain group. Many of them do not have pain. They have clicks and some lockings, not necessarily with pain. And we had the pain-related and the combined TMD group. These two groups on the right are pain groups, and these two groups on the left are non-pain groups. And you can see that the neck disability index was quite clearly higher in these two right groups versus the left groups. Interestingly, the intra-articular group also was significantly different than the healthy controls in terms of neck disability index, but you can see that the pain-related and the combined TMD groups were more impaired than the intra-articular group. So our study actually supported this pain-related connection, and this is one of the graphs that can show this support. What about posture? What do you think? Is posture plays a role in the connection between the jaw and the neck? So the answer is that there are contradicting findings, and higher quality studies demonstrate that the lack of a scientific connection between the neck, the posture, and the of TMD patients. And in our study, we actually found no significant difference between TMD groups and healthy controls in terms of forward head posture, but we did find some correlation between the amount of pain the participants had and the amount of forward head posture they were presented. So we did find some correlation, but without a statistical significant difference between the groups. So I can say that there is something there, but it's not strong enough to become statistically significant. Another parameter that plays a role in the connection between the neck and the jaw is the muscular performance of the neck, and mainly the deep cervical flexus, the longus capitis and longus colli. So some good high quality studies did demonstrate that patients with TMD tend to have a weakness and an impaired endurance in their deep cervical flexors. How can we assess it? We have the craniocervical flexion test using the pressure biofeedback, and that's what we used in our study. And we found a very interesting trend. You can see here that we have two parts of the test. Yeah, we have the activation and we have the performance. The activation is how can you hold your chin tucked one time for 10 seconds, and the performance is how many repetitions can you repeat this maneuver. So it's basically more strength versus endurance, these two areas. So the first line will be the strength, and the second will be more the endurance. And you can see that the pain related in yellow, yeah, so colored in yellow, the pain related and the mixed TMD groups were different to the intra-articular and the healthy controls. You can see that in terms of activation, which is more strength, they scored 5.3 and 4.6, while the intra-articular and the healthy were 7.2 and 7.7. Okay, so you can see that there is a significant difference. You can see that only painful TMD patients tend to be impaired in their in the strength of the deep cervical flexors. When we go to endurance, the same trend is there, and you can see that still the pain-related and the mixed TMD groups are different to the intra-articular and the healthy group. So I can conclude it like this, that patients with a painful TMD are very likely to present it with impairment in the deep cervical flexors versus healthy controls, but patients with intra-articular TMD are not likely to be presented like that. What about mobility of the cervical spine in TMD patients? So in our preliminary study that we published in the Journal of Musculoskeletal Science and Practice, we found that patients with a myogenic temporomandibular disorder, that was before the PhD, okay, that was a project that prepared the PhD, we found and we published that patients with a pain-related myogenic TMD are limited in their upper neck, but not in their lower neck. So we found that only in the flexion rotation test that assessed the mobility of the upper neck, this group of patients were different than healthy controls. But in the PhD project, we also found that the TMD patients were in some specific physiological movements were limited compared to the healthy controls. And you can see here in flexion, the TMD patients, the three groups of TMD patients were not different to healthy controls. You can see that you can see the 95% confidence interval. In extension, we could see that pain-related and mixed group were different and more limited to intra-articular and healthy controls. Also in right lateral flexion. In left lateral flexion, only the pain-related reached a significant level. In right rotation and left rotation, the two painful groups were limited compared to the other two groups. Again, we can see a significant trend. Patients with painful TMD are likely to be impaired in their mobility compared to the intra-articular and healthy controls. Interestingly, not in flexion. So interestingly, in flexion, this trend was not there. So bear in mind, when you see a TMD patient, it's not very likely that he will be or she will be limited in her flexion, but more likely that she will be limited in her extension and rotation to both sides. In flexion rotation test in the PhD project, we repeated the same trends of the preliminary study, and we could see that the pain-related and the mixed TMD groups were highly impaired compared to their intra-articular matched and healthy controls. And you can see here the 95% confidence interval of pain-related, for example, was 25 to 30 degrees to both to the right, and also 24 to 28 to the left. That means that on average, this group is positive in their flexion rotation test, which is positive. It means less than 33. So also the mixed group, you can see that to the right, they varied 23 to 43, but to the left, they were on average positive in their flexion rotation test. So we actually repeated same findings, and you can actually conclude and say that patients with painful TMD are more likely to be impaired in their upper neck mobility rather than the rest of the neck, but still they are limited in their general physiological movements of the neck. One more thing that we know, that if we treat one region, if you take TMD patients that have also cervical spine disorder, and you treat the cervical spine, they are very likely to get better in their TMD parameters. If you take cervicogenic headache patients with TMD and you treat their temporomandibular disorder, they are very likely to get better in the cervicogenic headache. So you can actually affect one system through by treating the other system, interestingly, and several studies actually support it. That's what we know. What don't we know? What are the gaps in literature? That's even more important. So the first gap is the causation. And the question is the cervical spine plays part of the etiology of temporomandibular disorder, not a comorbidity, but etiology, the causation, the causative connection is not clear. So you can see here the cat that probably made a mess, but we did not see this cat making the mess. That's why we cannot say for sure that there is a causation between this cat and the mess you see here, but maybe there is a correlation, but not a causation. But so we don't know who is the egg and who is the chicken. Is the masticatory system starts first and leads to cervical spine disorder, or is it more likely that the cervical spine starts the disorder and then goes up to the masticatory system? For that, you need a long-term cohort. You need to take a group of patients with one disorder, let's say the temporomandibular disorder, and follow them up for a long period of time and see if they are developing the cervical spine disorder more than the matched healthy controls. And we did that in our project, and we took 39 TMD patients without cervicogenic headache compared to 21 healthy controls, and we followed them up for 14 to 24 months, and we could see that only 3 of them have developed cervicogenic headache, while none of the controls developed cervicogenic headache. So the p-value did not reach the significant level, but we did see some maybe trend towards it, and maybe if we keep follow up this group of TMD patients, and we are still doing it, maybe in the future they will develop more cervicogenic headache cases, and maybe they will reach the p-value. But at the moment, according to our study, we cannot say that TMD leads to cervicogenic headache. But maybe in the future we will be able to say that. What about the comorbidity of cervicogenic headache in the TMD population? So up to our project, there was no study that assessed that at all. So we could not say what is the prevalence of cervicogenic headache in temporomandibular disorder population. And in our study, look what we found. We found that out of 42 healthy controls, only 2 were diagnosed with cervicogenic headache, which is quite similar to the prevalence in the overall population. In the pain-related, we found out of 37, 14 with cervicogenic headache, diagnosed cervicogenic headache according to the strict criteria of diagnosis, and 23 without. It's almost 40% of comorbidity, of prevalence. Intra-articular group, out of 17, we had no case of cervicogenic headache Combined, we had out of 27 with, 13 without, and overall in the TMD group, we had 21 with and 53 without, with overall prevalence of 28%. That's lots. So 38% and 35% in the pain-related groups is very high compared to the 5% in healthy control group, and of course it reached a significant level as well. So actually you can say that if you have a TMD, a painful TMD patient, there are quite good chances that he or she also suffer from cervicogenic headache. So 40% is quite a lot. Almost every second patient, every third to second patient has also cervicogenic headache. Another gap that was in the literature is that most studies did not check subgroups of temporomandibular disorder patients. So they assessed the TMD as one big group, but they did not assess them as small subgroups. So they took them as one group and did not divide the group into pain-related, disc-related, degenerative joint disease, etc. So in our study, we actually did that, as you could see before in some graphs before. But here you can see, for example, the deep neck flexors performance. And you can see that in the chart in front of you, you can see that healthy controls and intra-articular patients were quite similar in their performance of their deep neck flexors. But when you get to the pain-related and combined group, you can see that they are completely different in their performance. And that's why you can see that dividing the big TMD patient into subgroups makes the difference. When you have the pain-related group, patients with pain of painful TMD, they are very likely to be impaired in their performance of the upper neck. But when you have intra-articular patients, they are not likely to be impaired. That's very important. That our study was the first one actually to divide it like this. So after that, after saying that, should we assess the neck of every orofacial pain patient? And I would say if you have a pain-related TMD patient, for sure you need to assess his neck, his or her neck. And if you have an intra-articular, it's your choice. But I would say go for it anyway. But for sure, a pain-related TMD patient has to be assessed well with his neck, especially the upper neck. All the assessments that you know how to perform. And if you don't know enough how to perform assessment of the upper neck, then of course you can join one of the courses of Smart Education and myself in Belgium, hopefully after the Corona crisis, we will return and offer the courses again. So that's the time for questions. But you cannot ask me questions, but maybe tomorrow, because now I'm recording the lecture, maybe tomorrow I'll be able to go online and answer your questions. So that was my lecture about temporomandibular disorder patients and cervical spine involvement in this patients group. I hope it contributed to your clinic. I hope it was interesting for you, and I'm looking forward to see you face to face and not through all kinds of applications that are great and wonderful, but are not allowing us to be in a real touch. So goodbye to everyone, and see you tomorrow. My tomorrow, your today.